Hi, everyone. My name is Abhay Singh, and I'm Assistant Professor of Medicine at the Cleveland Clinic in Ohio. I treat patients with myeloid disorders and precursor states.
Dr. Singh, what is clonal hematopoiesis?
Yes, so clonal hematopoiesis, we've known about this for several decades now. The prototypical example being chronic myeloid leukemia, CML, which is a cancer of the bone marrow. But not every clonal hematopoiesis is cancer of the bone marrow. Typically, what happens is that there's an abnormal clone that is formed in the bone marrow. So all of us are born with certain number of stem cells, and the day we're born, these stem cells start duplicating, replicating themselves, doing all kinds of things to produce three kinds of cells: the red blood cells, the platelets, and the white blood cells. During the course of one's lifetime, as you can imagine with any sort of machinery that works day in, day out, there can be a defect that can happen in one of these stem cells, or the progenitor cells, or the daughter cells, if you may. And once that mutation develops, we think that the mutation gives a survival advantage to that mutated stem cell, or in comparison to the other cells in the body. So once there's a competitive advantage, these cells proliferates or clones at a faster pace than the normal cells. That's where the term clonal comes from, because it's cloning at a faster rate compared to its normal counterparts. And the process of, and then hematopoiesis is the process of blood forming, where the marrow forms the red blood cells, the white blood cells, and the platelets. So when there is a clonal component to that, we call that process clonal hematopoiesis. And if that clone gets unchecked, or if the clone continues to proliferate without any stoppage to that, that can become unavert malignancy or a blood cancer.
And what does the term CHIP or CHIP mean? And why is it so important for both doctors and patients to understand?
Yes. So about 10 years ago, there were three seminal papers that came out in the same year in 2014, and they had access to large databases and patient samples. And what they found was that in healthy individuals without any concomitant blood cancer or any malignancy at all, if they did DNA sequencing of the blood, they would find certain mutations or the clonal hematopoiesis that we spoke about, and these patients would have absolutely normal blood counts. So not understanding what that actually meant, it was termed as clonal hematopoiesis of indeterminate potential, or CHIP. Further analysis did show us that intuitively, because there was a clone that was pre-existing, a precursor state, such as a polyp in terms of colon cancer. So these mutations can go on to develop a blood cancer. That risk is very small, though, as more and more we're understanding that risk is very small. But what was surprising was that during those analyses, they found that patients who had CHIP mutations, they were at higher risk of, twice as likely to have adverse heart-related outcomes or cardiovascular disease outcomes. And that's why I think it is very important for our patients to understand, and our cardiologists, and our hematologists, and our primary care physicians to understand this terminology, CHIP, where there is increased risk of cardiovascular disease, and then forming a relationship with preventive cardiologist or cardiologist becomes really important, and also forming a relationship with a hematologist where frequent blood count monitoring can be done, so that there's a check on the disease, and there's a hope, and there's a role of early intervention, early detection, and prompt intervention to kind of halt disease or even prevent disease altogether.
And how does clonal hematopoiesis impact treatment decisions for doctors and patients deciding together what the best treatment plans are for them?
Yes, so as of now, if we talk strictly about clonal hematopoiesis of indeterminate potential, CHIP, which there are certain things in consideration for that definition, that there should not be any blood count abnormalities. So these patients should have normal blood count. There should not be any blood cancer, as we discussed. and they should have a certain mutation level, that there should be 2% or more mutation size or clone size that should be present. So that kind of forms the definition of CHIP. For now, there's only watchful observation for CHIP patients, and also I would not call patients. It's a phenomenon. So for individuals who are detected to have CHIP, watchful observation is the strategy that we follow, and we also have these individuals establish care with preventive cardiologists. There is another entity over the course of one's lifetime. The mutations may lead to low blood counts, and when these mutations lead to low blood counts, that's called clonal cytopenias of undetermined significance, or CCUS or CCUS. And in that scenario, we have several up-and-coming clinical trials. If there's a targetable mutation like IDH1 and IDH2 mutation, there are clinical trials that are available for those patients with CCUS. And then we understand that there's a shared inflammation pathway between cardiovascular disease, between hematological malignancy development. So many trials are looking at inhibiting inflammation and thereby decreasing the risk of hematological malignancy possibly, and also decreasing the risk of cardiovascular disease onset. So this has been studied in trials in cardiology world as well. The one that comes to mind has used the drug canakinumab, where they not only showed better cardiovascular disease outcomes by using that drug, but they also showed that CHIP mutation, especially the mutation called TET2, decreased in size with the use of anti-inflammation medication. So I think it's a very evolving field. We're trying to study this in the clinical trial space, but as of standard of care, watchful observation and establishing care with preventive cardiology is the strategy that we go to for now.